when everybody's grouchy and not...
I have no idea.
bored.
I don't know anything about that. Do a little quick review of the sensory pathways leading up to the clinical presentation, so not a bad idea? Yeah.
Could you go over this one picture of another one?
Sure.
I mean, if you don't want to,
Just tell me. Go ahead.
on page, on the right side, you said it's kind of complicated, and then another right side.
That one. Okay, so this one's not going to make sense. This one on the right or the left?
Yeah, right.
So this one's not really going to make sense until tomorrow.
Okay.
And we actually talk about the basal ganglia, and you can then have an idea about these other structures and how the basal ganglia fits in its relation to the internal capsule. We really haven't talked about the thalamus yet, except for mentioning a couple of sensory nuclei. This, as I said, this is a very odd-looking schematic. I get that. But the only thing for right now, what I want you to get out of it, is how these descending cortical projections are already segregated between corticobulbar and corticospinal. Okay? So imagine the pathways are leaving the cortex, and right away you've determined which ones are going to terminate in the brainstem for the cranial nuclei motor, and which ones are going to terminate in the spinal cord for the neck and below motor. Okay? And the fact that those corticospinals are already sort of segregated with regard to the different parts of the body they're coming from. They're going to go to, rather. Arm, trunk, and leg. All right. Anything else? No? All right. So these are the three major pathways. Lateral corticospinal, motor. Posterior column medial lemniscus, sensory, specifically vibration, joint positioning, fine touch, right? Discriminative touch. And an anterolateral sensory for pain, temperature, crude touch. And as we're going to see this morning from the clinical presentations, where these axons cross the midline, where the information crosses the midline, is absolutely critical that you understand. All right. So I gave you the two schematics of these pathways, and I realized on this screen it doesn't project nearly as well as it does on that one, but it seems like you either all have your handouts printed out or you have it on your own computer. So I thought I should just go over this one more time, just to make sure we're pretty clear about the pathway and what the components are, and then actually get right into the clinical presentations. All right. So, you know, the thing to remember about these pathways is what? Is your conscious awareness of where the sensory information is coming from. That you want to do what? You want to discriminate on the type of sensory information we're talking about, proprioception versus pain, crude touch versus light touch, right? Vibration versus temperature. And then you want to be able to quite precisely say that that information is coming from a very particular part of your body. So how does the nervous system do this? So the first thing is by these peripheral sensory endings. It determines the type of information it picks up. So if we're talking about a muscle spindle, we're talking about stretching skeletal muscle. If you're talking about tension in a tendon, right, we're talking about those Golgi tendon apparati. And so for the dorsal column medial lemniscus, it's all about this proprioceptive and the fine touch, right, Meissner's corpuscles at the end of your fingertips. It's this primary first neuron that we actually find the dorsal root ganglia, but it has these extensive axons, right? So the one is going all the way to your fingertip. So the one neuron is giving an axonal process that goes right to your fingertip to pick up that information. And then the axon extends into the central nervous system because you have to share it with the brain. And that axon ascends in the spinal cord until it finds the second neuron located in the medulla. Now, what's really cool about these axons is the fact that they can be tremendously long. So if you think about your big toe and that long axon through your leg, and then basically not synapsing, but extending out from the lower lumbar spinal cord all the way up to your brainstem at the level of the caudal medulla. The nervous system segregates out the body with regard to upper and lower halves when it comes to proprioceptive information. And these axons travel in two different fasciculi, gracilis and cuneatus. Gracilis for the lower part of the body, gracilis cuneatus for the upper part of the body. And fortunately enough, the names of the nuclei that the axons terminate in have exactly those two things, cuneatus and gracilis. So, the first synapse in this pathway, that is the first place we share information between the first and the second neuron, is in the medulla. Now, the axons from these cuneate nuclei or gracilis nuclei, they actually are the ones that cross the midline in those internal arcuate fibers and then ascend all the way to the thalamus. And it's in the thalamus we find one specific nucleus, the ventral posterior lateral, where this sensory information is clustered to. So that means that all the proprioceptive, vibration, fine touch information from the contralateral part of the body, from the neck down, right, funnels into this one little nucleus there. But the information cannot be haphazard, right? The information still has to be incredibly precise, because these thalamic nuclei then project onto the cortex in that homunculus where we go from the leg, the trunk, the arm, the face, right? So you know that exactly where the information is coming from. Now, these pathways, because they're having to do with the spinal cord, have nothing to do with the face. We're going to get to that in a moment. So, 3 neurons. The first neuron found in the dorsal root ganglion, the second neuron found in the nucleus cuneatus or nucleus gracilis, and the third found in that ventral posterior lateral. And then it's in the cortex that you become consciously aware of that sensory information from that part of the body, that you can say that that is a hot, heavy object in my left hand. Okay? So you've got a couple of different modalities there, temperature-wise. You've got a weight aspect to it, which is stretching your spindles and putting some tension on your tendons, right? And you can determine that that's a hot, heavy object in your left hand. You don't have to see it. You don't have to, your eyes can be closed. For the pain and temperature, there's a lot of similarities, but there have to be differences, or else the information would just all be mixed up. And so the big difference is the nerve endings in your skin are different for pain and temperature. They are for all the other modalities. And they're actually kind of like 3 nerve endings that pick up this information. But again, it's a dorsal root ganglion neuron, and its axons extend peripherally into your skin, pick up the information, and then share that in the spinal cord. Now the axons come into the spinal cord, and rather than ascending tremendous different distances, they actually find the neuron they're going to synapse with either exactly at that level or a little above or a little below. So pain information is like sharing, they need to share it with there's lots of neurons, and you get this term, this Lissauer tract. Don't worry about that, but it's just if you want to know what it is, that's this chain of neurons that are all connected with each other that serve pain. But the important thing here is the fact that it's the second neuron is found in the spinal cord, not in the medulla. And its axon then crosses in front of that central canal in this thing called the anterior commissure. And then it ascends in this anterolateral positioning in the spinal cord, which really means then that as the information for pain and temperature is ascending in the spinal cord, it's already bringing in that contralateral information. It ascends, and we see the fact that it ends up innervating those same thalamic neurons within that ventral posterior lateral nucleus, and again, those neurons then extend their axons out onto the cortex, where you become consciously aware of the pain and temperature information. Now, one thing I want to mention to you is that there are some interesting other terms put on here, like spinal thalamic, spinal mesencephalic, spinal reticular. Pain is an incredibly complex modality, you can imagine. And there's a lot of sharing of information. And we get the idea that this specific projection between the spinal cord and the thalamus actually sometimes is given its own name, which is spinothalamic. And the reason why it gives that is because it'll send off projections and collateral branches to other nuclei along the way, and specifically this thing called the periaqueductal gray. So this periaqueductal gray is around the aqueduct. Remember that from Dr. Cooper, the ventricles, right? Connecting the third and fourth ventricles. And it's a bit of gray matter, which actually is really important for the processing of pain information. So it's not just the fact that pain information goes to the cortex. There is this inclusion of lots of different sensors, the predominant one being this periaqueductal gray. And so sometimes you'll see these terms anterolateral and spinothalamic used interchangeably. But for me, I always use the term anterolateral, except on the next schematic I put up. So anyway, I talked about this. So here we actually have now our two thalamic nuclei, ventral, posterior, lateral. And if you think about what it's receiving, right, it's getting all the sensory information, all of it now, from the contralateral side of the body, from the neck down. That's what it's getting. Ventral, posterior, medial has everything to do with the face, and we'll do that very briefly. But even if you just look at the names of the pathways, and you see the fact that I mentioned the word trigeminal, that clearly is only associated with one thing: sensory innervation of the face. And so if you have trigeminal tracts, whatever their names are, you bet it has something to do with sensory information from the face. And those axons funnel into the different thalamic nucleus, ventral, posterior, medial. So just to mention now that the homunculus, so this is not, I brought this one from the motor lecture into sensory just to put it up there. But look at the similarities between the two. It's not like you've got to memorize two different homunculi, right? I mean, there actually are very, very similar things. So motor is here on the right in red, somatosensory on the left in blue. And you know, it's actually pretty similar. But the bottom idea is of what? Is this very precise localization of cortical neurons for your conscious awareness of sensory information in the body. And so, again, look at the representation of the cortical material you need for the human hand versus the human foot, right? Two completely different amounts of cortical material needed. You really have a lot of sensory information coming from your hand and not so much from your foot. And just for motor, as you have a lot of sensory cortical material for that, you do for the sensory information as well. So these homunculi are basically the same. Now the big difference, I would say, is the fact that even though there's a little bit down here for pain and temperature and stuff like that in the pharynx and the tongue, etc., this is much more important over here, as we're going to see, because this is actually all about motor activity for speech and where it's located in the cortex. So here we have two bits of cortical material now that we've done: a primary motor cortex and a primary somatosensory cortex. Their numbers, Brodmann numbers, are 4 for motor and 312 for somatosensory. So why are these arrows now connecting everything around? You know, why would primary somatosensory be sharing information with motor cortex? Why would that be going on? Well, believe it or not, and I hope you will believe me, this colleague of mine does a lot of this stuff at Queen's. So I'm going to pick up my coffee cup. I'm not aware if the coffee cup is full or if it's empty. But I could look at it and I could have a pretty good idea about what I think is going to be the weight of the coffee cup, right? Consciously, I want to pick it up. I reach forward, grab the coffee cup, and I already am now receiving sensory information, right, about the fact that it's not particularly hot, right? I can pick it up. It's not going to cause me any pain or anything like that. And the moment I begin to lift, that is, use the motor, conscious motor side of me, I need information, right? I need sensory information about its weight. So that sensory information needs to be shared with the ongoing motor information. And so that's why we're able to do things that have this wonderful fluidity to them. You know, if we're not consciously aware of how much the coffee cup weighs, but we become like knowing because you haven't told me. But because the somatosensory cortex is receiving that sensory information about weight, it shares it with the ongoing motor activity of the task to tell me how much I should exert, how much force do I have to use to actually pick the coffee cup up. So it's a wonderful loop between the primary motor and the primary somatosensory cortex, keeping each other informed as to what's going on by millisecond basis. And then there are other bits of cortical material around them that sort of help out with the entire process. And that's why they get these names association cortex or secondary, right, or supplementary bits to help out with the ongoing tasks at hand. So, let's do some lesions. Lesion number 1. And I think lesion number 1 is pretty straightforward. Now, I got to preface something here. I think I got it, but I'm a little red-green color. Well, I'm not a little. I'm red-green colorblind, and so you might know they actually put red and green up here. So if I get the colors mixed up, just bear with me. I'm pretty sure I'll stay with it. Okay. So we've got 3 colors here. Okay. So blue, vibration, and position. Again, vibration is what you're going to test. Position, like joint proprioceptive information, that's critical. Green, right? Pain and temperature. Okay? And then red is motor. So where are our pathways? Right? Those are our 3 major pathways. Where are they in the spinal cord? Well, there's lateral corticospinal, right? Shown on both the left and the right. We actually have our anterolateral pathway, right? In the front. We have our posterior columns or dorsal columns. Medial meniscus is higher. So that's in the back of the spinal cord. And then I thought they actually, they keep moving these terms around. But anyway, anterior ventral commissure is where the axons cut across from one side to the other. Okay? So, 3 colors, 3 pathways. What's happening? All right. Let's do case number 1. Case number 1 is like a complete spinal cord injury. So for those of you who, everybody pretty well knows Christopher Reeve, right? What happened to him? Superman, right? So he actually had a complete C1, the highest you can possibly get, right? C1 transection of his cord. So it wasn't just below the umbilicus as shown here, it was way up here. But we could move that line anywhere on this body, right? So this is more akin to, maybe if you're not from Canada, you might not know who he is, but this is much more akin to Rick Hansen. So Rick Hansen's a very famous guy in Canada who wheeled across Canada for spinal cord injury research, and he has this sort of injury where he's completely able to use his upper arms, but he has a complete transection where his lower legs don't work. So, if we imagine our spinal cord with descending motor activity, both left and right, ascending proprioceptive information, ascending pain information, and you just cut the spinal cord, nothing gets down, nothing gets up. So that means the fact that the sensory information coming from these limbs is not getting to the brain, and the brain motor information, like wiggle your toes, is not getting to the appropriate motor neurons in the spinal cord to consciously have that act, right? So that's very clear. I think everybody would kind of get that one, right? A complete spinal cord transection. Nothing works. You get that? Good. Well, they do occur, absolutely. But you also can get these other ones referred to as the Brown-Séquard syndrome, where you actually have a hemichord lesion. That is, only one side of the spinal cord is lesion. Okay? Now look at our patient. There's a very peculiar presentation going on here. Now, we know that the side of the lesion is on this one right here, on this side here, so on his right. And and we have this line which demarcates approximately the level of the lesion. But we have this patching of red and blue on the ipsilateral side, and this complete green on the contralateral side. So something interesting is going on here. So this is why it's important we think about where these axons are coming from. All right. So what I've done is drawn this one on the board because I think this one's a good one to draw. And so let's just go through it. So there's our lesion, right, with the big X's. That's our lesion. So these things represent your dorsal root ganglia. I hope everybody gets that, right? The dorsal root ganglia. This is our spinal cord. There's our lesion. I think you get the idea that descending motor information, right, has already crossed the midline. It doesn't matter that the voluntary activities are arising from the contralateral cortex. It's the fact that that descending motor information, as it's coming down, is interrupted. So that the motor neurons that are below this level of the injury in the spinal cord are denervated. They're not receiving that motor information. So you get this paralysis on the side of the injury. The descending information doesn't make it past the injury site, and therefore these motor neurons down here, your lower motor neurons, are not receiving information. They don't work. Straightforward? Good. Proprioceptive. Well, if I draw my proprioceptive neuron here, we know the fact that its axon picks up peripheral information like stretch and skeletal muscle, and its axon comes into the spinal cord and does not synapse but ascends in the dorsal columns. And you can see that it doesn't get very far, right? It's interrupted by the lesion. And so if you think about it, on the side of the lesion, we have both the motor deficit and a proprioceptive deficit. The information is not getting down beyond the lesion, and the proprioceptive information is not getting up beyond the lesion. The weird one is the green, right? The weird one is the green. How do we explain this? Well, if you remember what's really going on with the green neurons, it's this. The neurons on the contralateral side, the pain neurons, send their axons into the spinal cord and synapse with another neuron in the spinal cord. It's this pain neuron whose axon crosses the midline and ascends. And so that's why you get this loss of pain information from the level of the injury below. Because if I draw the other pain neuron right here, on the same side now, come on, black, keep working. It crosses the midline and ascends and is not affected. So what's being affected is this ascending pain information from the contralateral side of the body. Because these axons cross the midline at the level of the spinal cord, and then they are disrupted. They don't go any higher. So that explains why the whole half of his lower body has that green. But what is with this little patch of green right here? So imagine doing a pinprick assessment on this individual, right? So if we actually go on the lesion side, not knowing exactly where the site of the lesion is, right? You would actually be doing this. So you'd take your little pin, right? You'd be going down and you'd go, yes, I feel that. Yes, 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 yes. No, no, yes, 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 yes. And then you go back and you really want to look, and that's odd. And then you come on this side and it's like, yes, 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 yes. No, 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 all the way down. Why is this happening? Well, if you think about the site of the lesion, there's probably one, if not two, spinal nerves that are damaged in some way. And if you think about the incoming pain information, it doesn't even get into the spinal cord. And so you get this little tiny zone that actually tells you quite precisely where the site of the injury probably is in the spinal cord. So do you kind of get it? So at the site of injury, our pain axon that's coming into the spinal cord is disrupted. So that's not even getting the information into the spinal cord. So that's why you have the little patch of green on the affected spine. The pain neurons just a couple of levels below, their axons get into the central nervous system, they get into the spinal cord, and they cross the midline. So on the affected side, there's no problem. However, on the contralateral side, the information comes into the spinal cord, the axons certainly cross the midline, but now they are damaged, and that information does not get any higher. Now, Brown-Séquard syndrome can be caused by a tumor growing and pushing on the spinal cord, and hopefully, if that's what's happening, the tumor can be removed, and with time, because those axons have not been severed, right, you'll get some restoration of function. But if this was due to some sort of horrific trauma, say like a gunshot wound that came in and just sliced off half the spinal cord, right, there'd be no hope for recovery whatsoever. So the great thing about Brown-Séquard is this. It really challenges you to think about how these axons are navigating through the spinal cord. Their information, right? And so I hope that me drawing it and walking through it has actually helped out a lot. But just think about the site of the injury and what's going on below that. Is the information able to get beyond the site of the injury, or is it disrupted? And if the information is coming in and crossing the midline and going up to the unaffected side, then there's no problem. Great. Now, thinking about these neurons, these ones that cross the midline, we now have something called a central syndrome, where due to probably some sort of an infarct, we actually get a loss of vascular supply and resulting loss of tissue at the very core of the spinal cord. So, what's going on here then with that? Why do we actually have this sort of presentation? So what we end up with is a presentation of a patient where they actually have this cape-like appearance, where their shoulders actually have this loss of pain and temperature information. But look at it, it's bilateral. So what is really affected of the three things we've done? What is affected by having a lesion at the core of the spinal cord? Well, for pain and temperature fibers, it's they're crossing to that thing called the anterior commissure. So that the pain, let me go back to red. Sorry, black's not working. So these pain neurons synapse. These pain neurons come in and synapse. And then these axons, as they form the anterolateral columns, pass through this structure here called the anterior commissure. And it's this structure that is specifically affected in this central core lesion. And so you get just the loss of pain and temperature, and it's the axons that are crossing, so that's why you get this bilateral appearance. For this one here, which now is a much more severe loss of tissue in the spinal cord, we go back to something that looks almost akin to the transection, the complete transection, where we have everybody being affected. Pain, temperature, proprioception, and motor activity. And there's probably just a little bit of sparing at the urogenital due to some fibers traveling at a very peripheral location within the spinal cord. So this one, you kind of get. Again, we kind of like damaged the entire spinal cord. But this one, it's really about that central part of the spinal cord being affected and really cutting off the blood supply or damaging these crossing fibers in that structure called the anterior commissure, which passes in front of the central canal. We can actually have other lesions that affect just the dorsal columns, and they would do it probably unilaterally or bilaterally. But in this case, it's a bilateral, and you get this posterior cord syndrome. And completely what you're getting is just the fact that you're losing those proprioceptive axons, and from that level and below. So motor's not affected because your motor pathway's out here laterally. Anterolateral is not affected because it's in the front. And so you have this complete and singular presentation of loss of proprioceptive information. And as much as you can actually have something going on with the posterior 1/3 of the spinal cord, you can have something going on with the anterior 2/3 of the spinal cord, and that's more akin to the anterior syndrome. So why do I emphasize those terms, posterior and anterior? Posterior 1/3, anterior 2/3. Well, these things really match that vascular territory, right? You had those two posterior spinal arteries that were supplying blood to the posterior third, and the singular anterior spinal arteries supplying blood to the anterior 2/3. So an occlusion of these blood vessels could give rise to these two completely looking syndromes. And the important thing here is the fact that this infarct would be affecting both lateral corticospinals on both sides and the anterolateral systems on both sides, and causing this effect for both pain and temperature and motor. Whereas with the posterior 1/3, you're only affecting proprioception. So I think these are very helpful in getting you to look at the spinal cord and ask yourself which pathways are traveling in the different parts of the spinal cord. And if I were to tell you that, the spinal cord really has dozens of pathways passing through, and these are only 3, and that's not so bad. But these are 3 clinically relevant pathways. These are the things you're going to see people have affected, right? The other ones are very minor, more diffuse, smaller in function, right? But these are the 3 big ones. All right, so we've done, seems a lot from the neck down, right? What about the neck up? Now, I'm going to distill this down to the bare essentials of what you need to know. What do you need to know about the neck up with regard to sensory information? It's important, but do you have to know all this ridiculous information about pathways and tracts and everything in the central nervous system? No. But if I were to tell you that, once the nervous system's got a good thing figured out, it sticks with it. Right? It sticks with it. So what do I mean by that? If you have a clear understanding of posterior column, medial lemniscus, anterolateral system, then you can take that information without even worrying about the names and directly apply it onto trigeminal. Because if you think about it, there's proprioceptive information from the face, there's fine touch from the face, there's pain and temperature from the face. And if those 2 pathways do certain things from the neck down, then chances are there must be pathways that are almost just like them from the neck up. And you don't have to worry about all these nuclei names like chief sensory nucleus and spinal tract and the spinal tract nucleus, mesencephalic tract. You don't have to worry about any of that stuff as long as you get the basics. So what are the basics? 3 neurons, right? That's the basics, 3 neurons. Guess what? Trigeminal, it's 3 neurons. The first neuron is located in a ganglion. Oh, well, from the neck down, it's dorsal root ganglion. From the neck up, it's the trigeminal ganglion. The trigeminal ganglion has those pseudo-unipolar neurons in it that are picking up pain and temperature, proprioceptive, fine touch, vibration. Oh, all right, that's all the same. And they have to bring that information into the central nervous system. Not the spinal cord now, but the brainstem. They share that information with neurons found on the same side. That applies over there as well. And these neurons, the second neurons, it's their axons that cross the midline. That's exactly what's happening. These second neurons, regardless of where they're located, in some nucleus called trigeminal or something like that, these pathways, they then go on to innervate the specific thalamic nucleus. Not the BPL, but rather the BPM. And then these thalamic projections now go on to the cortex, the somatosensory cortex, specifically that area, the homunculus, for the face. You don't have to worry about trigeminal lemniscus, trigeminal thalamic tract, that word trigeminal tells you I'm in the facial nucleus. I'm in the face, having to do with sensory information for trigeminal. You don't need to worry about all these names. That you understand trigeminal ganglion, absolutely. That you get that for pain, temperature, proprioception, light touch, crude touch of the face. It's a 3-neuron chain. First neuron's in the ganglion. Second neuron is in the brainstem. It's the second neuron's axon that crosses the midline. The thalamic nucleus is right next to the other one, so the VPM, the VPL, and then we have the projection onto the homunculus for our conscious awareness of face. And so just like everything having to do with the neck down, right, that VPM is receiving all the sensory information from the contralateral face. So the VPM over here is receiving contralateral information from the face. The VPM over here, contralateral information from the face, right? We're only just showing you the one side. So, don't get bogged down in the minutia for trigeminal. If you go on and do neurology, absolutely. But when you actually meet a patient who has some degree of facial pain, right, that you understand trigeminal, you understand the fact that trigeminal information's got to get into the brainstem and funnel to the thalamus, onto the cortex, absolutely. So we've already done this with cranial nerve 5, so you can do this again. This is actually just a breakdown of the different, this is a nice chart to help you. And again, don't sort of get bogged down in the minutiae of these pathways, but clearly the face has proprioceptive, fine touch, crude touch, and everything going to the VPM. And then, last but not least, taste. And the only reason why I mention taste is because taste is actually an interesting sensory modality that has nothing to do with trigeminal, because we know that taste is actually being carried by the chordotympany nerve, which links up to facial. So we think of facial being from that anterior 2/3 of the tongue. But the only thing I show you is the fact that here's a sensory pathway, a special sensory pathway, and look, it's a 3-neuron chain. I don't remember the name of the ganglion, but there's a ganglion picking up the taste information. And I don't really know the name of the nucleus in the brainstem, but that's where the information goes. But look what these neurons do. They actually project bilaterally onto the VPM. And of course, this is only of interest because I want to just show you, because I'm never going to ask you about taste, and patients aren't going to probably complain to you about too much about taste. But it's just interesting how these, once you've worked out a system for processing sensory information, right? 3 neurons. First one's ganglionic, next one's in the central nervous system. Funnel the information to the thalamus, and then project onto the cortex for your awareness, right? But in this case, because taste is not something we need to localize in our mouth, left versus right, That's not important, right? It just projects onto both cortices. So and that just makes intuitive sense. We don't need to know that taste is coming from the left side of our tongue versus the right. Okay, so that's sensory. So I could not have emphasized enough about what's so important here to know, and that's a good understanding of these 3 pathways. Okay, so the 1 motor pathway and the 2 sensory pathways. All right, so in another 10 minutes we're going to take a break, and so we need to go right into what is undoubtedly a heavy topic, and that's the brainstem. The great thing about the brainstem that we're going to do, and this is kind of method to my madness why I actually do my lectures this way, is the fact that we talked about the brainstem generally. I've mentioned how the brainstem consists of the midbrain, the pons, and the medulla. We then mentioned some things already, like the medulla has those nuclei cuneatus and gracilis in it, right? And how 10 of the 12 cranial nerves are associated with the brainstem. And if you look at this schematic down here, we've actually done a few things already. So we've done the cranial nerves. We've actually done these long tracks. So what would be 3 long tracks that must pass through the brainstem? Corticospinal / corticobulbar, right? Anterior, posterior columns, medial lemniscus, and anterolateral, right? I mean, we're trying to get information from the spinal cord to the thalamus. They're passing to the brainstem. Motor information is in the cortex, heading to the spinal cord to affect those lower motor neurons. So those are our 3 long tracks. And then we have this connection between the brainstem and the cerebellum. And then finally, we have this structure called the reticular formation. So in a way, we've done a few things already. And so what we need to do now is think about, at each level of the brainstem, this midbrain, pons, and medulla, what am I likely to find here? So if you're presented with a patient that has a massive infarct in the lateral aspect of the medulla, how would you expect that patient to present? What structures do you think are in the more lateral versus medial aspect of the medulla? What structures are you expected to find in the pons? And I'm not talking about all the nitpicky little structures, right, that are in there from a neuroanatomy point of view. I'm talking about the major ones. Our 3 long tracks and our 10 cranial nerves, right? That's it. So where can we find them? And the only way we can think about this is by looking at sectional views of the different parts of the brainstem. So just a bit of gross anatomy again. So this anterior view here shows us the midbrain, the pons, and the medulla. And this big thing up here is the thalamus. The thalamus is not part of the brainstem. The thalamus is part of the diencephalon. I have pointed here a couple of odd structures. Well, I've already mentioned about pyramids. So these pyramids, if I were to look at them histologically, are nothing more than our corticospinal axons. Corticospinal axons are what you find in the pyramids. So when someone would say to you, this patient has a pyramidal disorder, you know it's motor. Because the pyramids have to do with that corticospinal pathway. And you can see how superficial they are in the brainstem by these 2 bumps on either side of the midline. Now these other 2 bumps, lateral of the pyramids, anatomists got a little, odd with naming things, right? And so there must be a superior versus an inferior, but they kind of thought it looked like an olive. And I guess it has a sort of roundish shape. And so anyway, it's called the inferior olive, and we'll see that there's a nucleus inside there called the inferior olivary nucleus that contributes this protrusion out of the brainstem. Now, as I mentioned before, I'm not going to quiz you about, these rootlets and the brainstem. But it is going to be important for you to recognize that we can parcellate our cranial nerves into these 3 levels of the brainstem. And I hope that if you think about starting up here, right, because vision and olfaction are up here, right? Somewhere up here must be vision and olfaction. And if you think that numerically they do go down the brainstem, so 3 is next, 12 is last. So if you think just intuitively, 3 must be in the midbrain, right? Some of the middle numbers, right, must be in the pons, and our last few numbers must be down here in the medulla. And sure enough, that's exactly what we find, right? But it's got to be a bit more specific than that. A lateral view just shows us the same structures again. And this thing here called the cerebral peduncle, which is in the midbrain, are these large bundles of corticospinal and corticobulbar tracts, but we'll see that on the schematic. And so there you can see the pyramid and the inferior olive again. So these are anatomical features that let you know you are actually in the midbrain, the pons, or the medulla. So there are some anatomical landmarks that we're going to be using. I've already talked about the whole idea of osmication of human material, how it turns the myelinated tissue very dark, and it keeps the gray matter relatively gray looking. And so what we're going to be doing is looking at these cross-sectional views, starting in the spinal cord and going through all the way up to the midbrain, and asking, where are our pathways? Where are some big, important cranial nerve nuclei? Okay? So, let's just start here, and we'll see how we go. Now, you can, with my permission, no problem, delete lots of words, because I've got lectures made that are given to different audiences, and so what I've tried to do is make it very clear that we only have 3 pathways we have to worry about: lateral cortical spinal, and then there's a whole bunch of other motor pathways on here that we talked about, certainly anterior cortical spinal, but rubrospinal, lateral vestibular, not so much important, right? And so we have to recognize, if we're in the level of the spinal cord, the cervical spinal cord, where do we find lateral cortical spinal? So what's shown on these schematics, just so we're all clear, is that on the right-hand side, the nuclei, the pathway are outlined in blue, and they're not outlined on the other side. And then up here in the top corner, we actually have a sagittal view of the brain showing where the section is taken from. All right? So, why is this important then? Why should you think about these cross-sectional views of the brainstem and ask yourself, well, what's there? Well, one good reason is about the advances in imaging, right? So now, you will be presented with images of the brainstem at some point in time, where someone's going to ask you, what level do you think this is, and what structures would you find there? I know it's going to happen. And I know it's going to happen because the first time I came down to St. Vincent, I was shown these Step 1 exams, which we don't have in Canada. And, I was shocked to see the fact that they actually presented a cross-sectional view of a brainstem. And, it was at, what nucleus is this? And I looked at it and I thought, that seems a little unfair. But then, the more I thought about it, I thought, well, actually, it's not really all that tough of a question. Because if you just learn to recognize these 3 typical views of the brainstem, 3 of them, there's a good educated guess as to what these things are. And in fact, by using your knowledge and some of the tricks I'm going to give you, it wasn't such a bad question. It's whether you were taught that information. I think that was the bigger thing. So, here we have lateral cortical spinal. What can we say about that pathway? Last thing I'm going to say before we take a break. What can we say about that pathway? The axons we find there are from where? They're from the contralateral cortex, number 1. Right? We see axons here. If it's lateral cortical spinal, all of those cross the midline. Of all cortical spinals, it's 85%. But once you call it lateral cortical spinal, 100% of these axons are from the contralateral cortex. Okay, we can say that. And the other thing that we can say is the fact that these axons are what? Are they upper or lower motor axons? They're upper, right? We have yet to find the lower motor neuron resides in the spinal cord. This axon is going to make this neuron in here work. This axon comes from the cortex. This axon, the axon from this neuron is going to extend out and innervate skeletal muscle. So the axons in that lateral cortical spinal pathway are upper motor neuron axons. Okay, so let's take a break and we will commence. Okay, so, no, perfect. So, here we have a cross-sectional view of the cervical spinal cord. And the one pathway on this view that is absolutely important is that lateral cortical spinal. And recognizing that these axons are now contralateral to the cortex from which they originated, and that these are still upper motor neuron axons, so that they will ultimately innervate motor neurons throughout the spinal cord at whatever precise level they're supposed to influence, and it's those lower motor neurons that project their axons out to innervate skeletal muscle. What about our other two sensory pathways? Well, here we actually have gracilis and cuneatus. So these are actually the two columns that we find in the dorsal columns. Gracilis is always more medial than cuneatus, and we actually find those two. And again, if you look at the relative size of it, you know, proprioceptive information from your upper limbs, there's a lot more stuff coming in than from your lower limbs. So little gracilis, by comparison, it is small compared to huge cuneatus, right? And that's just, you know, it makes sense. A lot more proprioceptive information coming from your upper limbs and lower limbs. And our anterolateral system, carrying our pain and temperature, crude touch information, has that positioning over here. So these large things are the posterior or dorsal columns, and then anterolateral. Those are our three pathways. Now, we get into the caudal level of the medulla. Now, this is where things begin to actually, now we're actually in the bona fide brainstem. So, we have what? We have three pathways, and now we have to start thinking about some what? Cranial nerves, if possible. So, if we know the fact that it's within the caudal medulla that you find these nuclei for cuneatus and gracilis with the exact same names, then hopefully that's what you see. And so, in fact, if we look at the midline being right here, then we actually have the gracilis nucleus, cuneatus nucleus, which are the grayer ones, and we can still see the myelinated axons forming sort of a mantle around it as they come in to innervate those neurons. These two large bundles down here are our cortical spinal axons now before they cross the midline. So why do I say before they cross the midline? Because these axons, that decussation of 85% of corticospinal occurs at the cervico-medullary junction. We were just in the cervical, we're now in the medulla, we've missed that junction, that's on the motor lecture, but just above that junction we actually have the pyramids themselves, and now these are now ipsilateral to the cortex. So there's no crossing yet. And in fact, this is where you have those prominent bumps on the medulla that makes them look like the pyramids. So we get the pyramidal name to them. What else do we have here that's important? So 2 you can scratch off, 3 you can scratch off, 5 anterolateral. So if you look at it, the spinal cord had this really nice sort of anterolateral, you know, kind of smile on the side there, right? But we can't really have a purely anterolateral positioning now for this pathway because of these huge pyramids, these huge bundles of myelinated upper motor axons. But if you look at it, the anterolateral is as anterior and as lateral as it could possibly get. So it's trying its best to be in the front, and it's still off to the side here. Okay. So there are our three pathways. Cortical spinal, before they cross. Now we have our nucleus cuneatus, nucleus gracilis with their associated axonal bundles, and anterolateral. Now the one that's immediately adjacent to it, so this is now branded. The one that's immediately adjacent to it is trigeminal. And if I were just to tell you that at every level of the brainstem, we're going to have trigeminal processing. Right? Trigeminal processing. What does that mean? That means information from the face is going to be processed in nuclei at every level of the brainstem. Then we should see that word trigeminal at every level. And in fact, we do. So here's a nucleus that's associated with the trigeminal cranial nerve, and it's processing that sensory information. And so we'll see, so of all our cranial nerves, the only one that actually goes through all the levels is trigeminal. And we'll do that as a review at the end. It's these internal arcuate fibers that are so important that actually project from the nucleus gracilis, nucleus cuneatus, and are bringing that proprioceptive information from the ipsilateral side now to ascend on the contralateral side, heading to the thalamus. So these internal arcuate fibers are only occurring at this level of the medulla. Okay? And they're taking that proprioceptive information now from the same side and bringing it over to the opposite side, where those axons will now ascend as that medial lemniscus part. So if we think of that below this level, it was the dorsal columns, and above it, we actually call it the medial lemniscus. So we get those two names that put together to describe this particular pathway. Okay. So now, this is a more rostral level of the medulla. And this is where I'm going to actually share a particular trick with you as to how to identify these things. How do we know this is the rostral level of the medulla? Well, so here we actually have a cross-sectional view here. So again, midbrain, pons, medulla. There's a caudal and rostral end. So rostral means closer to the nose. Caudal means closer to the tail. So the rostral medulla, how do I know that's the rostral medulla? Well, on there is this big squiggly structure. And this big squiggly structure on either side is the inferior olivary nucleus. And that outpouching is the inferior olive itself. That's the anatomy. Immediately below it, we still have our pyramids, our corticospinal axons. And so if you want to identify the rostral medulla, look for this big squiggly structure here, the inferior olive, and that will tell you exactly where you are. Now, what about our three pathways? Well, we know that the pyramids are still there, and we know that the pyramids are corticospinals. That's these big myelinated tracts down here. Anterolateral is still doing its best to be anterior and lateral, and that's 5. So again, with the inferior olive and the pyramids in the way, it can't be in the front, but it has its best positioning it can. 6, again, is trigeminal, because we know trigeminal goes throughout. But now here's an important one. Here is the medial lemniscus. So now these are the proprioceptive, vibration, fine touch information that is ascending in the brainstem, which is now on the contralateral side of the brain. And it's a long, narrow bundle of axons. And this is where you get this idea of the ribbon, because it's going to have that appearance here, it's going to change in the next level, and change it again at the level above that. So it gets this idea of a ribbon. It's malleable, right? And we know it's not really dynamic. This is during development. But in the brain, we actually have the medial lemniscus taking on different shapes. But when you hear the term medial lemniscus, right, you have to directly associate it with what functions, right? Proprioception, fine touch vibration, from the contralateral side of the body, the neck down. So, there are pathways. Corticospinal, medial lemniscus, because now the dorsal columns were in the spinal cord, and anterolateral. Now, I haven't mentioned much about cranial nuclei yet, except for trigeminal, and now we actually have some. So here, at this level of the rostral medulla, we can actually find nuclei that are contributing to cranial nerves. Now, what do I mean by this term nuclei? So, if you think about 12 is a motor nucleus. It's going to consciously make you move your tongue. And so 12, that's right there, has motor neurons in it that project out to innervate the tongue. 10 also has neurons in it that actually project out to innervate their structures. And Vestibular cochlear actually has lots of neurons, but if you think about it, what's going on here is the fact that they're receiving sensory information, right? They're receiving vestibular information or they're receiving ear information. So it either could be from the cochlea or vestibular, right? So they're receiving information. Now, if you go back and think about these cranial nerves, we had some that were what? Purely motor. Hypoglossal was purely motor. It was all it had to do with it. Vestibular cochlear is purely sensory. All right? It's special sensory, but sensory. And vagus is mixed. It's got a bit of motor, a bit of sensory, a bit of parasympathetic. It's got some visceral things going on with it. It's mixed. And it turns out this is a great little trick to help you identify these nuclei. So say on your step 1 exam, there's one of these images, and it's clearly the rostral medulla because it's got the big squiggly thing on it, right? And all it's showing you is the section, and then it's labeling this nucleus closest to the midline. Okay, induction. Well, in the rostral medulla, this is toward the end of my cranial nerves. So it can't be 3, 4, 5, 6, 7, right? They should be higher. Rather, it should be some of the lower numbers. But it turns out, from an embryological point of view, the vertebrate nervous system is incredibly cool. Because what it does, it generates all the purely motor nuclei closest to the midline. And all the purely sensory nuclei furthest from the midline. And the ones that are mixed are in the middle. Huh. And if you look at it, it's true. Hypoglossal, closest to the midline, is purely motor. Cochlear and vestibular nuclei, furthest from the midline, purely sensory. And the one right in the middle is actually mixed. And hopefully, that's a hard and fast rule that we can stick with. And that should help us. So if the answers were, right? So say the answers were 12, 10, 6, 5, and no, not 5. Let's leave 5 away. How many questions do you have on how many answers do you have on a question? 4 or 5, typically. Varies, does it? We're only allowed to have 4 now on questions at home. All right. So let's say it's just 4. So let's say it's 8, 10, 12, and 3. Well, 3 you can throw out. I mean, this is not the midbrain, okay? So 3 can be gone. And then of those, if it's pointing to this structure here, you can ask yourself, well, of the 3 remaining cranial nerves, which one is purely motor? And that would be hypoglossal. And therefore, it's closest to the midline. And so that should help you in identifying these nuclei and what they're doing within the brainstem. Okay? So that should actually help out a lot. This one down here, nucleus ambiguous, is actually a nucleus that's really about the pharynx and larynx, and it's being shared with a bunch of them, just in case you ever come across it. Nucleus ambiguous. Hence its name, ambiguous. It's very hard to find. It's a little tiny thing. So, that is the rostral medulla. We found our pathways, and now we actually have some cranial nerves. But look at the numbers of the cranial nerves. We're in the lower end here. So we've got everything from 8 down to 12. And we know trigeminal is at every level, so somewhere in here is trigeminal. And if we go back now and we ask ourselves, okay, so was that rule still good, right, about trigeminal? Like, you know, if it's purely sensory, should it be more laterally situated in the brainstem? And there it is, way out here, laterally situated, sensory nucleus. All right? So it's not in the middle, it's not certainly at the midline, right? It's more laterally situated, and that's trigeminal. So that's the rostral medulla. The pons. Well, the pons is attached to the cerebellum by these huge peduncles. And don't worry about this squiggly shaped structure here because you'll never see that one again. So it was more the outpouching, right, of those olives giving rise to the inferior olivary nucleus. And those squiggles up there are not the inferior olivary nucleus, but it clearly looks very different from that. Now sometimes you'll see the pons represented with the attachments to the cerebellum above, or sometimes you'll see with them cut off. But we know that our three major pathways have got to be going through here, right? Corticospinal, anterolateral, and medial lemniscus. They've got to be passing through here. Where do we find them? Well, now in the pons, we have the pons with these big crisscrossing axons going from left to right. And if we think about the corticospinal axons going down, they're actually coming out of this green tube. So if you imagine you've got this crisscrossing action from left to right here, corticospinals have got to be coming out, right? They're heading down toward the spinal cord. Anterolateral and medial lemniscus, look what's happening with these two pathways now. It's kind of cool. They're going to the same place, right? They're going to the ventral posterior lateral thalamic nucleus. And a moment ago, they could not have been further apart. And it seems like now that they're going to the same place, they're starting to get closer together. And I certainly am not going to be one to say that these are pathways within the pons you should be able to identify. The fact that you know that they're there and that they're traveling together makes a lot of sense, because they're all going to the same thalamic nucleus. Trigeminal is even traveling close with them, but the trigeminal is going to go to the ventral posterior medial, not the ventral posterior lateral. So we have our corticospinals and we have our two sensories. Now, here is an important concept. Within the brainstem, we know we have these things called corticobulbar axons. What are they? These are the cortical neurons in the part of the cortex, the motor cortex, that are influencing motor activity of the cranial nerves. Collectively, they travel as a group. We don't know which ones are going to facial, which ones are going to glossal, the hypoglossal, etc. But they travel as a group. So there's one thing you can say about corticobulbar axons, that by the time you reach that cervicomedullary junction, they're done, right? If they're innervating the cranial motor nuclei, and those are only found in the medulla, then you're not going to find a corticobulbar pathway in the spinal cord. But you will find it in the brainstem. And they travel with these corticospinals, but they'll jump off. So of these three here, of these three nuclei here in the rostral medulla, right? Vestibulocochlear, vagus, hypoglossal, right? Which ones do you think get these corticobulbar axons? Receive this corticobulbar input? Well, definitely hypoglossal, because they're about the motor activity of the tongue. So these corticobulbar axons form synapses with our hypoglossal neurons. Without getting into any great deal of it, and we know that vagus has to do with the pharynx and the larynx, and they too receive corticobulbar axons. So if we think now that hypoglossal is receiving cortical inputs, and we know the hypoglossal nucleus is our 12th cranial nucleus, which sends axons out to innervate the tongue, which of the two designations is hypoglossal? Upper or lower motor neuron? If it receives corticobulbar inputs, is it an upper motor neuron or a lower motor neuron? It's lower, right? Because it's receiving a cortical innervation. It's being regulated by the cortex, and that's no different than all the motor neurons in the spinal cord being regulated by corticospinal axons. These motor neurons in hypoglossal, in vagus, are being regulated by these corticobulbar axons. And we can't find them specifically, we just know they're there. Now, at this picture, which now we've lopped off these peduncles that actually connect the pons to the cerebellum, we find two more cranial nuclei. We find 7 and 6. Now, 7 and 6, we can actually think about, well, what are their functions? 6 is abducens, and it only innervates the lateral rectus, so it's purely motor. 7 has a lot of motor activity, but it has some parasympathetic, right? It had a little bit of sensory function. It even had taste, right? Clearly mixed. Look at the relative positioning of the nuclei within the brain stem. Abducens is closer to the midline than facial, the nucleus. However, the axons are kind of crazy what they do. But even the axons exit out in a more medial versus lateral arrangement between the two of them. It's just one of these peculiar things that the facial axons, before leaving, loop around abducens before they exit out. It's just a curious thing. But nonetheless, purely motor exits out more medial than the one that's mixed. So now, if we think about the brainstem, now we're getting somewhere, right? Now if we think about the brainstem as a box, a simple box, and we think about the three parts to it. So this is midbrain, this is pons, and this is medulla. Now in these boxes we can start putting some cranial nuclei. We found 8, we found 10, and we found 12. Which really means what? That 9 and 11 must be really small nuclei, to the point that even probably neuroanatomists aren't 100% sure exactly where all the different components are. We can really see 8, 10, and 12, and chances are 9 and 11 have got to be in there as well. But we clearly identified these 3 nuclei, right, in the sections. In pons, we now have found 6 and 7. There they are, abducens and facial. One is purely motor, closer to the midline. One is mixed, further away from the midline. And then, last but not least, is the midbrain itself. Within the midbrain, we have these structures referred to as the tectum, which is the roof. The tegmentum is more the body, and this thing called the bases. These bases, these cerebral peduncles, look what's in them. Corticospinal and corticobulbar. Because who else is receiving corticobulbar inputs, right? So we think of these corticobulbar, right, inputs, definitely to facial, right, definitely to hypoglossal. You know, when we think about, there's the movement of the eyes are a little different. They are corticobulbar, but when we're thinking about these real voluntary things, right, like smiling and speaking, if you just think about speech, the formulation of speech, we also have these corticobulbars coming into vagus. So all of our corticobulbars. So, because our pathways are still ascending or descending, here is corticospinal, that's descending, ipsilateral to its cortex. And now look at our sensory pathways. They're all traveling together. They've all just coalesced together because they're all going now to the next level of the brain, which is the thalamus. The thalamus is above the midbrain. So we now actually have our 3 sensory pathways all traveling together because they're all going to the thalamus, everything from the neck down, ventral posterior lateral, from the neck up, ventral posterior medial. How do we know this is the midbrain? Well, there are a couple of really big, other than its wonderful shape, these two big round things, these red nuclei, which contribute to that rubrospinal pathway, which I said don't worry about, but at least now the red nucleus can help us identify that this is a cross-sectional view of the human midbrain. These big round nuclei here are a dead giveaway that we only find in the midbrain. The substantia nigra is a critical nucleus we'll be doing tomorrow that's all about motor activity, and it's a major source of dopamine within the brain, and it is that nucleus that's lost in Parkinson's disease. Now, you would say to yourself, well, hold on a minute. Substantia nigra, it doesn't look very dark to me. Well, that's because this is now still stained with osmium. So you miss that really pigmented appearance of the substantia nigra, which I'll show you tomorrow. The superior colliculus is about eye movement and the control of eye movement. And so it's up there. So, how about cranial nerves? Well, look, there's an all-important one right there, oculomotor, 1, 2, 3. 3 is right there. And look at its positioning. It could not be closer to the midline, right? Closer to the midline. Because remember, oculomotor has immediately adjacent to it and situated just a little bit laterally Edinger-Westphal, where the preganglionic parasympathetic neurons are located. And you can only distinguish those two groups of neurons by special stains, which you will never see. But at least we know there's ocular motor, 4 of the 6 extraocular muscles, plus levator, palpebrae, superioris. So now, if we look, we know that 1 and 2 are not associated with the brainstem. If you recognize a cross-sectional view of the midbrain, and the question is what nucleus, and it labels a nucleus and it gives you 5 cranial nerve options, it can only be the 1. It's got to be 3. With regard to the pons, you recognize that level. It gives you a bunch of cranial nerve options. Well, it can only be 6 and 7. And 6 is going to be more medial than 7. And within the medulla, to be fair to you, they can really only, anybody could ever only ask you about 8, 10, and 12. And we've already identified how we can look at that in an order between sensory, mixed, and motor in a lateral, mid, and closest to the midline arrangement. So we can fill in a few numbers, right? We know that in here we're going to have 9 and 11, right? Glossopharyngeus, spinal accessory. They've got to be kind of in there somewhere. Okay? So then we come back here. So 7, 6. What about 4? Trochlear is such a tiny little nucleus. Because if you think about it, it's only activating one muscle. It's a tiny little nucleus. And again, you need a special stain actually to find it. So, who's missing? Come on, who's missing? Trigeminal. That's because trigeminal cuts across all the levels. At every level, there is trigeminal. Okay? And relative to them, so if someone were to ask you, well, where's trigeminal on here? Relative to ocular motor, it's got to be laterally situated. I don't know where it is, but hopefully no one would ever ask you that. So, all of our cranial nerves, we can take each of these levels and say 3, 6, 7, 8, 10, 12, with trigeminal cutting across all of them. Great. I'm doing well. So, 2 things to mention about the reticular formation. Well, probably more than 2, but it's all here. So, what is it? The reticular formation is a collection of neurons that you find diffusely arranged throughout the brainstem. Is that true? Yep. That is a level of the midbrain now I've got to recognize. That's a level of the pons now I've got to recognize. That's a level of the rostral medulla, because I can see the inferior olivary nucleus there, yep. And then even down into the spinal cord itself. Very extensive collection of neurons, which are referred to as the reticular formation. For the people who like to study the reticular formation, I think there are almost a dozen distinct parts of it. You don't have to know those. All you have to recognize is that there's a rostral and a caudal component. And for these, if you just think about one function, you'll be well ahead of the game. The rostral reticular formation is all about alertness, consciousness. Whereas the caudal reticular formation is all about reflexes, autonomic function. So, alertness, consciousness, that's going to be very important, right? When you actually think about a space-occupying lesion within the brain, pushing down on the midbrain, distorting function, and then getting to the point that not only do you have cranial nerve nuclei upset, or you actually have pathways that are not working, but now you depress the consciousness of the patient. So there's definitely space-occupying lesions that can push down on the midbrain, on the pons, and then lead to a disruption in consciousness. The caudal reticular formation is much more about those reflexes that we take for granted, cardiovascular reflexes, respiratory reflexes, right? Autonomic reflexes, all sorts of things. But the bottom line of it is this, that when we think about the brain stem, right now we've done cranial nerves, we've done our 3 long pathways, and now we can add on to this the reticular formation. Obviously, for something like maintaining consciousness, there must be tremendous diffuse projections everywhere, and indeed there are. And so this is just to show you, not for you to learn this in any way, the idea that these axons project diffusely throughout the brain. And so clearly coma can be caused by a dysfunction of this upper or rostral reticular formation within the brainstem. Okay? So, then we end up with a schematic like this. That's got all of our major players on it. And it's kind of a bit of an overkill. There's a lot there. But having said that, though, many of these things are kind of important. What's interesting now is the fact that we can look at this and we can now ask ourselves about vascular territories within the central nervous system. So when it comes to this level of the rostral medulla, there are these 2 very curious vascular territories. There's one that's more medial and one that's more lateral. And they're both supplied by vertebral arteries, but one is actually purely vertebral, and the other one is kind of a junction between vertebral and anterior spinal. And if you think about an occlusion to these arteries, what might you expect to be the deficit? Well, we know what about the brainstem. We know the fact that there are 3 long tracts and there are a bunch of cranial nuclei. So if we were actually to think about an occlusion to that medial portion here, that's colored in darkest red, we actually have the hypoglossal would be affected, the medial lemniscus would be affected, and the pyramids would be affected, cortico-spinal axons. And what they've done very nicely for you is to actually break it all down as to how these syndromes manifest themselves. So this medial medullary syndrome, an infarction cutting off the blood in the medial aspect of the rostral medulla, would result in what? 3 really odd presentations. If you think about it, because the axons have yet to cross the midline, right, you would end up having this contralateral weakness, because now the information is going to ultimately cross the midline, and you'll end up with a contralateral weakness of the leg or the arm. But because the ascending information in the medial meniscus is already now on the opposite side, you would get a contralateral decrease in positioning and vibration. So if we think about now these two major pathways lying side by side, receiving the same vascular supply, we know that these axons here will eventually come to the contralateral side and influence motor neurons on the contralateral side of the body. The proprioceptive information is already ascending now on the contralateral side. That is, the axons in here, right, are bringing the information from the opposite side of the body to the thalamus. So a presentation where you have an occlusion of this part of the rostral medulla, you're actually having a presentation of contralateral loss of proprioception. But because hypoglossal is all about the hypoglossal nucleus on the right innervating the right side of the tongue and vice versa, you would have a ipsilateral weakness of the tongue. Because hypoglossal or its axons are not working, and therefore you would get that ipsilateral tongue weakness. You'd ask the patient to protrude their tongue and it will deviate to the side of the lesion. 3 is kind of easy. So the 3 here together may be very, very different. But it's interesting because if you were given a patient where you were told it's contralateral weakness of the body, the arm and the leg, it's contralateral loss of proprioception, and the tongue is affected, where could these 3 things be occurring at the same time? And the only answer is in the medulla, where these 3 entities are traveling in some proximity to each other, and that would be in the medulla. The lateral medullary syndrome or Wallenberg syndrome, wow, this person is clearly not well. Because we have so many things now that are affected. What are affected? Well, if you go back and look at it, so why don't we do it the opposite way now? Why don't we actually look at what's wrong and make sure the fact that we agree that these structures would actually be in the lateral medulla? So the individual is going to have a bit of uneasiness, that's ataxia. They're going to have some vertigo, dizziness, and nausea. And when people don't really know what end is up and they're unsure about their balance, they always feel nauseated. So we think that vertigo, nausea is all about vestibular, right? My uprightness in space. Then we would expect to find the vestibular nuclei in that lateral aspect of the medulla. Well, vestibular is completely sensory, so that makes sense that it would be in the more lateral aspect of the medulla. All right. We actually have an ipsilateral facial decrease in pain and temperature. Again, remembering the fact that the information's got to come into the brain stem, then you're affecting it on the same side before that information's even had a chance to be processed. So that makes kind of sense, that it's ipsilateral. And again, trigeminal being sensory, laterally situated, the lateral medulla. That's turning it to be pretty good, because nothing completely motor is coming up yet, right? Contralateral decrease in pain and temperature, more sensory. That actually kind of makes sense, because we know that by the time we're in the brainstem, all the sensory information, right, from the neck down, is on the contralateral, is being conveyed on the contralateral side. So that actually makes sense that we would actually have a loss of pain and temperature from the neck down. Then we actually get into so we've got a little bit of loss of taste. Not quite sure where the nucleus solitarius is, but taste is sensory. That makes sense. Now, with regard to this hoarseness and dysphagia, that actually has to do with this nucleus ambiguus and the larynx and the pharynx, etc. And this is just because of where the nucleus is actually located, this nucleus ambiguous. And even though it is predominantly motor, because it's ambiguous, you don't really have to worry about exactly identifying. But that's situated out over there as well. And lastly, which ties into what I talked to you about yesterday, is this Horner syndrome, these descending, and I really don't like this term, sympathetic, these descending regulatory, hypothalamic regulatory projections. So what would Horner syndrome be? Horner syndrome would be a droopy eyelid, right? Because the sympathetics aren't working, a droopy eyelid, and would the pupil be dilated or constricted? Excellent, constricted. So, what we have here now is a whole bunch of things wrong. And clearly, this individual is probably not going to do very well. So there's really a lot wrong here. And it's kind of like a dog's breakfast of a whole bunch of different things. Whereas here, we've got this curious, bringing together of three things. And so what I want you to do is think about how these things present and how you can link them up to the anatomy. And the same thing can apply to the pons. You can actually have these different syndromes of the pons. But, I've sort of taken away all the unnecessary detail for you and just ask, generally speaking, what would you expect to see? Generally speaking, a lesion of the pons, what would you expect? So because we know we have our corticospinal axons going down, we'd expect to have a contralateral arm and leg weakness. But what about now the face and the dysarthria? What kind of axons are carrying that information? Well, that's corticobulbar. These are the bulbar axons innervating 7, and these are the bulbar axons innervating 10 and 12, right? So that inability to properly formulate words, right? Using your tongue, your pharynx, your larynx, and your mouth to formulate words properly. And that's really the major one there with regard to what we've done. And then we can do the exact same thing here, and it gets a bit, unnecessarily complicated. But the bottom line of it is, if we have lesions within the midbrain, we would expect to see again some of that contralateral weakness, that hemiparesis. But now we could involve what? The third cranial nerve, third nerve palsy. So now you'd have a patient who has this contralateral presentation of paresis, like paralysis, and yet something wrong with the third nerve. So how would the third nerve palsy manifest itself? So what could we say first about the eyeball? Where would the eyeball be situated on the ipsilateral side? So the patient's looking at you, and on the one side, the eyeball is looking directly at you. But what about the positioning of the eyeball with third nerve palsy? Now only what? Two muscles are working. Lateral rectus, pulling it out. And because superior oblique has a thing about turning things in, you actually get the eyeball being turned out and down and out. So actually you would get this positioning of the eyeball sort of over here, right? Down and out. And you really notice that. What else would you notice about the patient with regard to their eyes or their eyelid? Would they have ptosis? Absolutely they'd have ptosis. Because we need levator palpebrae superioris and the tarsal muscles working together to keep the eyelid up. If levator palpebrae is not working because of the third nerve palsy, then we get a droopy eyelid and we get the ptosis. And then finally, what about the pupil? Before you start shining light into the pupil or anything, you're just looking at the patient and you're looking at their pupils. Would you expect them to be of the equal size between the two eyes? Would you expect it to be dilated or constricted? Dilated, right? The unopposed actions of the sympathetics. Because remember, it's the parasympathetics that are traveling along with ocular motor. So those would be affected, and you would end up with a dilated pupil. So this is just a breakdown of a lot of information. You can look at it, but there's a lot of nonsense in there that you really don't need to know all that information. But if you break it down into simple things like long tracts, reticular formation, we haven't done cerebellum yet, it's actually pretty good. And then cranial nuclei as well. So there's a lot of extra information in there, like somatic, sensory, general somatic, visceral, right? We haven't used a lot of those words. And if you don't recognize the nucleus, don't worry about it. Like the salivatory nucleus, solitarius nucleus, don't worry about those. Okay? So that's not bad. We actually got to the brainstem. I was wondering if I would get through that today. So that's not bad. So, distill it down to the basics. 3 long tracts, 1 motor, 2 sensory. 10 of 12 cranial nerves, which I could not have given you a better schematic for, to think about. So if all you have to do is now learn, what do these 3 levels look like? What should I find in each one? What would be the relative positioning of these major structures? And if you think about the medulla having the pyramids, well, that's where you're going to find cortical spinal, right? If you think about the midbrain having cerebral peduncles, cortical spinal plus cortical bulbar, because the bulbar axons are coming down to innervate 7, 9, 7, 10, and 12. And eye movement's a little different. So if you distill it down to those basics, plus the fact that you have a rostral and caudal reticular formation, and all you have to do is think about rostral alertness consciousness, caudal autonomic, cardiovascular, respiratory, very easy. And I hope that, you know, as you go on, you'll recognize that I really have kept it to the most clinically relevant things you need to know. And thinking about, you know, how you may in the future be presented with scans, and, you know, to use some of this basic anatomy and apply it to the clinical knowledge as to what you should find at all these different levels with regard to the major things. 3 pathways, 10 cranial nerves. And we didn't even do all 10 cranial nerves. It was really just, what, 6? 6 of those 10. So 4 7, because trigeminal is always through there. So 3 we really can't find because they're kind of small or not very particular, and so that should help you. And the midline, motor, mixed, sensory should really help, okay? All right, so when I come back at 11 o'clock,